So our next speaker is Eugene Woltering. Gene is the James D. Reeves Professor at LSU. He also directs the NETS group, and by the way, they helped underwrite the breakfast, right? Right. So we want to thank them all for that. So Gene is a surgeon by training, but he also is probably one of the most knowledgeable surgeons with neuroendocrine disease that I know, and he's been in this business for a very long time. And he's worked on a lot of basic science projects. Has had a lot of innovative ideas, has many patents in these areas. And today what Gene's going to talk to us about is the importance of biomarkers in the diagnosis and treatments of neuroendocrine tumors.
Thank you very much. I appreciate the opportunity to chat with you. We're going to talk about biomarkers today. There's a lot of controversy on whether or not people have biomarkers and need biomarkers for diagnosis and or long-term determination of recurrence, persistence, or growth of disease. Again, for people who asked to see this slide, again, these are the primary sites. We have about 3,000 neuroendocrine patients that we follow, and the vast majority of them are small bowel and pancreas, and then lesser rectum, gastric, lung, etc. 3 reasons to test biomarkers. 1, to diagnose or confirm a diagnosis in NET. By themselves, they do not diagnose anything other than suspicion. To evaluate prognosis, I'm going to show you some data today that says this number, if it's positive, you're going to die. If it's below that number, you're going to live forever. Others are markers of change of size. As the tumor grows, the marker goes up proportionally, and that doesn't necessarily reflect prognosis. So diagnose, prognosis, and changes in volume over time. There are functional biomarkers that cause symptoms. We talked about that extensively yesterday. Gastrin causes acid, insulin causes low blood sugars, etc. And then there are non-functional biomarkers like chromogranin, pancreastatin, neurokinin, and even those at very, 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 very high levels can cause symptoms occasionally. There are basic blood things. This is something I put in the slide pack that you ought to be able to access from Marianne and Bob's work. But the bottom line is there you can take an organ of where the tumor arose and tell what markers are commonly used for that. Like if you have a gastric carcinoid, pancreastatin, gastrin, gastric pH, and antiparietal cell antibodies are useful in monitoring those patients by and large. There are the same kind of things for midgut, jejunum, ileum, cecum, and appendix, pancreastatin, neurokinin, serotonin, and either plasma or urine 5-HIA. In the old days, and if you listen to the Europeans have never figured it out. They have 5 chromogranin assays. They use them interchangeably, but they all have different baselines. So that's screwed up. Number 2, the most common used drug in the world are proton pump inhibitors like Nexium, Afex, all those kind of protonics, etc. They immediately start to raise your chromogranin A, and if you've been on them for a year or so, they can keep your chromogranin elevated for months on end. If you read the work that's in the insert of the drug, they're only FDA approved for 12 weeks of use. I have patients who've been on PPIs for 12 years. And so that's not a very good marker because it elevates the chromogranin. PPIs increase gastrin as well as chromogranin. Pancreastatin levels, on the other hand, in the same group of people don't elevate with PPIs. So if you're on PPIs for GERD or Barrett's esophagus and you have to have a marker, pancreastatin is the marker of choice. HINDGUT has very few markers. We measure neuron-specific enolase and substance P. I got to tell you, I think it's futile. Very, very few of those are ever elevated. Neurokinin is the emerging marker as a prognostic marker. It doesn't reflect the day-to-day changes in tumor volume, but tells us that you're going to live or going to die over a period of time. It's a member of the tachykinin family. It's produced from the same precursors as substance P. At very high concentrations can affect gastrointestinal motility, vasodilation, and can cause flushing. Plasma concentrations are elevated in midgut nets, and we store and secrete neurokinin. And there are a group of people that I got to tell you are false positive neurokinin that have markedly elevated neurokinin but have no evidence of disease. And we don't know, we thought we understood that those were Parkinson's patients on Cinemet, but it turned out not to be as we projected. Does monitoring neurokinin levels make a difference in patients with midgut nets? This was work done by Joyce Ardell from the Royal Infirmary in Belfast, Northern Ireland. And what she showed was that if you have a midgut carcinoid, like an ileal or a jejunal, and if you had a neurokinin higher than 50, you had an 87% chance of dying in 3 years if you weren't one of these patients that had no disease that I talked about as a rare exception. By contrast, if your neurokinin has never gone over 50 or went over 50 but you had surgery or chemotherapy or PRRT and it brought it back under 50, you have just a very small chance of dying in the next 3 years. We went ahead and worked with Joy Ardell and the ISI folks and tried to look at the effect of neurokinin measurements on getting short-term and long-term prognosis. Again, if you look at the small bowel, vast majority of our patients that we see are small bowel. And this is the paper that's in surgery on neurokinins predicting stage 4 survival. And this tells you, look at the upper level. These are people who have normal neurokinins, and this is survival if you have elevated neurokinin over 50 picograms per or nanograms per mil. And if you look at the survival, it's clearly different. It sort of tells you that if you have neurokinin neurokinin that's elevated, you need to have new aggressive therapy, and we need to be more aggressive in these patients. These patients here than those patients up here if they have a normal neurokinin. What happens if you lower the level? We did 50 nanograms per mil. What if you brought it down to the upper limit of normal in the ISI team's assay, which is 40? A new and different study. Again, the paper. And we hypothesized that if your neurokinin levels remained elevated despite treatment with surgical cytoreduction, you have a bad prognosis. Again, patients diagnosed with small bowel who went surgical cytoreduction at our institution or a place like Dr. Odorizio's with Dr. Howe or Dr. Wang or Dr. Pommier. And then we got their demographics and histopathology. They were grouped by the trend of their neurokinin. Survival rates were calculated from the date of the first neurokinin measurement. 267 patients that were in this study, All patients underwent surgical cytoreduction and received any other therapy they needed, like chemotherapy or PRRT, etc., as part of standard of care. Again, group 1 had neurokinin levels that were continuously less than 40. These were the best prognosis. Group 2 had increased levels, but after surgery or therapy came back down to less than 40. And group 3 are the bad guys who were elevated, had surgery, had therapy, but it's still elevated. And again, look at 10-year survivals here. If you had always had normal neurokinins, 62% alive at 10 years, 78% if you had elevated, but we were able to fix you. You were, again, 78% 10-year survival. But look what happens in group 3 if your neurokinin was elevated and we couldn't fix it. None of those people were alive at 10 years. And you look at it graphically, always normal, abnormal but fixed, abnormal and not be able to be fixed. You can see survival is abysmal. In conclusion, patients with small bowels who have undergone cytoreduction have high 2-year, 5-year, and 10-year survivals, serial monitoring plasma, 5-HIAA, and serotonin and things like that, but mostly neurokinin tells us who has the bad prognosis, and we need to have concentrated, get those people into clinical trials, etc., because what we're doing isn't working. The other thing that we see is an emerging role of a marker is in pancreastatin. Again, I mentioned in the European group and in America originally, chromogranin A was the marker of choice. Pancreastatin is a fragment of that. If you look at chromogranin A, it's the size of a blimp, and the pancreastatin is the size of the tire on the blimp. And so, again, a much more accurate marker than chromogranin, not affected by proton pump inhibitors, whereas chromogranin vastly affected. Multiple chromogranin assays, for God's sakes, the most common thing that I get called about chromogranin is either they're on PPIs or they had it measured one time at Quest, one time at Mayo, one time at something like LabCorp, and all three values are way different, and they think they're dying, but it has to do with what assay they had done. Duodenal NETs are rare, but their incidence is increasing. They represent about 6% of the people that we see. We need to have a biomarker that can identify patients who are duodenal NETs who have a bad prognosis. Again, this is our nearly 3,000 people that we've seen. Duodenum is relatively a small group, 140 duodenal neuroendocrine tumors. Many of these are seen, diagnosed, and treated by endoscopic resection, and only a few require open resections or laparoscopic resections. And again, a predictor of survival in patients with duodenal NETs. We hypothesized that pancreastatin levels that were elevated predicted a poor prognosis in primary NETs of the duodenum, and that was either identified by EGD, endoscopic ultrasound, exploratory surgery. All of the tumors that we're talking about have been reread by our pathologist. All patients were seen at the neuroendocrine program that I work at and run in New Orleans. Again, we collected all the demographics. Patients were sorted according to the normal or elevated biomarkers, calculated median survival in months, 5-year and 10-year survivals for each group. And again, these are all duodenal lesions, so don't apply that to your small bowel or rectal or lung. Again, there are 2 assays in America. ISI, the vast majority of ours has a level of less than 135. Cambridge Biomedical, that sends their stuff through Quest, is 88. We only had 2 patients that we had Cambridge biomarkers for these. And again, we did univariate analysis, and there were several things that were statistically significant. But when you did multivariate analysis, the only thing that fell out was pancreastatin as a prognostic marker. If you look at, again, prognosis and elevated pancreastatin, again, I remind you, these are only in duodenal lesions. You can see that there are 2 groups. The group that have normal pancreastatins and live forever, the people who have abnormal pancreastatins and in spite of our best efforts go on to die. So very important prognostic information for their pre-op pancreastatin. But even if you now have an elevated pancreastatin and we are able to correct it, you have a superb survival long term. If we can't correct your elevated pancreastatin after cytoreductive surgery, you're in big trouble. And again, I encourage those people to get into clinical trials. Overall, if you look at, this is work done by Jim Howe, the pancreastatin is again confirmed to be a good marker of prognosis. And pancreastatin also projects the outcome of surgical cytoreduction in small bowel. This isn't published yet. This is currently, that manuscript is like 99.9% done. And again, small bowel, about 35%. 967 people we're talking about in this study. And we hypothesized that if you had an elevated pancreastatin following surgical cytoreduction, you were in trouble. Data analyzed from all the people that we saw with small bowel, not otherwise specified, ileal or jejunal NETs. All patients received surgery plus any other thing that they needed, PRRT, etc., as standard of care. They were sorted into 3 groups. Group 1 had an elevated pre-op pancreastatin but normal post-op. 2 had normal pre-op and normal post-op. And group 3 had either a normal or elevated pre-op, but post-op developed an elevated pancreastatin. So these are the guys you would say are in trouble. If you look at 10-year survivals, again, group 1, a good prognosis group, normal pancreastatins, 82% alive at 10 years. Elevated pre-op but normal post-op, 65% elevated, but the people, only 34% survived if you had an elevated post-op pancreastatin. So again, a group of people that you've identified who need more aggressive therapy than these people who have 80% 10-year survivals. Again, look at the Kaplan-Meier survival curves. And again, this is work done by Brianne Voros, my research assistant in our group. These are the people in the good prognosis, and this is the bad prognosis and highly statistically significant. In conclusion, patients with small bowel NETs who undergo surgical cytoreduction, they have high 5 and 10-year survival rates up to 80–85%. Serial monitoring of pancreastatin is useful and can help identify people who have a poor prognosis and need more aggressive therapy and go into clinical trials. And with that, I think I'll end and take questions as part of the question and answer. Thank you very much.